will be an interesting and useful talk on prostate cancer and hormonal treatments. We've got a great evening ahead of us with a fantastic speaker, Mr. Dhanasekaran, a urology consultant at Sandwell City Hospital, who I'll introduce shortly. Thanks also to Ash, Ellie, and the AstraZeneca team for arranging this meeting tonight. Prostate cancer is a really big problem in the UK. It's the most commonly diagnosed cancer in men in the UK, and the risk of developing it obviously increases with age. And as we all know, we're very much seeing an aging population where conditions such as cancer are becoming more common. Part of our roles as GPs is early identification and referral of patients with suspected cancer. And GPs are being urged to prioritize this with more of an emphasis on early cancer recognition. And with QOF as well, you might have seen there have been some changes there to try and prioritize early diagnosis of cancer. And symptoms of prostate cancer, such as the increased frequency, nocturia, are sometimes just put down to old age, and patients can sometimes present to us quite late. There have been some education campaigns that you might have seen on TV as well to raise awareness of prostate cancer and symptoms. But we as GPs need to remain vigilant to aid early diagnosis and treatment and to raise patient awareness. The second big C, the dreaded COVID, has probably made things even worse, as we know a lot of patients are not presenting when they have symptoms and are leaving things for later. Some patients also, both older and younger men, may find it difficult to talk about what they see as embarrassing problems over the phone, especially to female GPs. And we really need to try and normalize these conversations. We have come a long way in the treatment of many conditions, including cancer, and there are constantly new developments being made. Nowadays, fortunately for many patients, cancer isn't something that they die with. Cancer is something that they die with rather than it being something that they die from, which is a huge achievement. Tonight, Mr. Dhanasekaran will be discussing hormonal treatments for prostate cancer and supporting evidence. We are very fortunate to have Mr. Dhanasekaran with us tonight. He has a number of different roles in the world of urology and a huge amount of expertise. In addition to being a urology consultant, he's also Deputy Head of Academy in Sandwell, West Birmingham NHS Trust, an honorary clinical tutor, a core urology postgraduate tutor at the University of Edinburgh, an editor in various journals, published in journals, chapters and books, a number of different things, with an interest in education. He's got a wealth of experience. So we're in very good hands this evening. And without further ado, I will hand over to our resident expert, Mr. Dhanasekaran. Thank you, Mr. Dhanasekaran.
Thank you, Dr. Vinu Manivasagam, and it's my pleasure to see you all. And as Dr. Vinu has mentioned, prostate cancer is not only a very commonest cancer, the evidences and the available treatment is so commonly changed every year by year. And thank you for AstraZeneca for sponsoring this meeting. I will share my slides. I'm very happy for anyone to stop me in between if there is any burning questions, and certainly there will be a question answer session in the end. Few minutes. I'm sure everyone will be able to see the slides. I'll get my laser pointer. So today our aim is to discuss the challenging perceptions on the hormone treatment for the prostate cancer. Dr. Vinodini Manivasagam and for myself, this slide shows the disclosures. Why there are some challenging perceptions? What are the key points we are going to discuss today? We are going to briefly discuss the prostate cancer epidemiology, classification, management, the role of androgen deprivation treatment overall, and various evidence behind the 3 clinical settings of prostate cancer treatment like high risk, locally advanced and metastatic, and a very brief note on administration of Zoladex safe system device, how the device is different from the other systems available. Let us look into the epidemiology first. Prostate cancer is one of the most commonly diagnosed cancer for men in UK. Especially if you see this graph in the age of 65 to 69, They form a very big part. It appears as if the cancer evidence is bit lower when the patients are above 80, but it is because the number of patients above 80 is less. Otherwise, if a man lives for longer, the chances of prostate cancer increases decade by decade. This slide explains the various initial steps what we are doing. Most probably as a GP, you will be doing a PSA test, which is the major trigger for referral to us. And once the patient reaches us, we will do appropriate MRI scans and biopsies to get the proper histology and make the diagnosis. Of course, clinical examination with digital examination forms a major part. Then we do the TNM staging. The staging is important only for the patients where there is a very high suspicion of metastasis or locally advanced disease. The biopsy is graded by using the Gleason scoring system. As you can see here, if the histology shows discrete, well-formed glands, it is a better prognosis. It starts with Gleason 6, and slowly as the differentiation of the cell decreases, the histology will become absolute lack of gland formation. It has the worst prognosis. You may have seen when the urology consultants writing back to you with the treatment follow-up, we label the patient by using the Gleason score. It starts with 6 and finishes at 10. Higher the number, worse the prognosis. Overall, prostate cancer is divided into 3 main groups: localized prostate cancer, locally advanced prostate cancer, and metastatic prostate cancer. At the same time, NICE guidelines is useful in differentiating the prostate cancer into low risk, intermediate risk, and high risk. As you can see, the 3 main things used in risk stratification were PSA, Gleason score, and clinical staging. The easiest way to remember is I will remember the values for the intermediate risk. It is PSA 10 to 20, Gleason score 7, clinical staging T to B. Once we are able to remember this, anything lesser than that is low risk, anything higher than this is high risk. Explaining the clinical stage 2 means single nodule in one half of the prostate. 2B means multiple nodules in one half of the prostate. 2C means multiple nodules bilaterally. What is the role of hormone treatment in prostate cancer? Let us know the physiology first. These hormone treatments block the man's androgens at different level. We have 3 predominant group of drugs. The first one is reducing the androgen production by the testicle itself. That's where the Zoladex comes into play, which is the main drug modality we are going to discuss today. So from the testes itself, the hormone production of the testosterone is reduced. How it happens? LHRH agonist or analog to the actual gonadotropin releasing hormones. Because of the LHRH agonist, the negative feedback is blocked. I will explain this further in my next slide. The next method of hormone blockade is by blocking the androgen synthesis throughout the body. Why it is important? Apart from testes, adrenal forms a major role in producing the testosterone. So in specific patients, there is a need to block the androgen synthesis throughout the body. That's where abiraterone comes into play. The third method is by blocking the action of the androgens throughout the body. By this method, the testosterone level will be in circulation, but their bondage and action in the intracellular mechanism is blocked. The commonly used drugs are the age-old flutamide, bicalutamide, and newer ones like enzalutamide and uplutamide. So this is a very nice diagram showing us the mechanism of the LHRH hormone agonist. So we have hypothalamus and we have hypothalamo-pituitary system, and we have the pituitary. Pituitary is secreting FSH and LH, which stimulates the testes to secrete testosterone, which feeds for the growth of the prostate. Even the benign growth depends on the testosterone. Obviously, the malignancy is heavily dependent upon the testosterone. Once there is a Zoladex injection given, the LHRH agonist falsely gives a hope as if that there is more amount of GnRH. Since they are analog to each other, it blocks the normal secretion of the luteinizing hormone from the anterior pituitary. Because of blockage of luteinizing hormone, it blocks the testosterone release also. I hope this is useful when you are able to understand the next few slides. Now, as far as the androgen deprivation treatment is concerned, there are three main clinical areas where it is very useful. First one is the high risk localized prostate cancer, then locally advanced prostate cancer, then metastatic prostate cancer. Obviously, if you go back to the previous slides, we are not bothered about the localized low grade, which can be treated like active surveillance or surgery or radiotherapy. We are more concentrating on the advanced disease stages. How androgen deprivation treatment is useful in all these three categories, we will going to see with help of some evidences. There is insufficient evidence to conclude that LHRH agonists are equivalent. LHRH agonist, even though there is some minor difference between the various drugs like goserelin, triptorelin, leuprotolin, there is no strong evidence to say that one type of LHRH agonist is better than other or inferior to other. Zoladex has clinical data across all three prostate cancer settings which we discussed. In case of high risk localized and locally advanced prostate cancer, there is a good role for adjuvant Zoladex. There are various studies supporting that. I'm not going to get into too much of studies and statistics which will be quite boring for you, but end of the day I will make sure that you are understanding the overall use of the injection Zoladex and where it is useful equivalent to the other drugs and where it is more superior. In neoadjuvant Zoladex, there are some studies which clearly proven, especially with radiotherapy, the neoadjuvant drugs have given very high improvement in the values. And in case of metastatic prostate cancer, as we all know, we can't make the patient cancer free. Our aim is to control the prostate cancer as much as possible so that the patient remains symptom free for the rest of the life. We all know that orchiectomy has a good role in metastatic setup. When they compare the Zoladex with the orchiectomy, there is a good evidence to say that Zoladex is as effective as surgical castration. If we take the statistics to the very minute extent, there are some small differences which I will explain in the future slides. Zoladex as an adjuvant therapy in high risk localized or locally advanced prostate cancer. In a newly diagnosed prostate cancer, which is high risk localized or locally advanced, there is a randomization of 1:1. Half of the patients received radiotherapy for 36 months plus 36 months of Zoladex, while the remaining patients received radiotherapy alone. There is a very clear evidence to say that Zoladex outperformed the radiotherapy alone group. Hormone therapy was given at the time of progression. 71% received LHRH analogs and 24% received other treatments. In 10 years, 40% relative risk reduction was noted due to death with Zoladex therapy. So that's how with the Zoladex, the radiotherapy seems to be much better in giving the outcome compared to radiotherapy alone. Just to give you a preamble of what happens actually in the clinical setup, when the patient is seen by the urologist, we start the patient on the bicalutamide. Bicalutamide is the drug which helps in control the tumor flare for the first injection. As we discussed before, Zoladex is an agonist. So it mimics the actual body luteinizing hormone. So there will be a transient increase in the luteinizing hormone and transient increase in the tumor flare. This is very important, especially when the patients have some significant findings like the bone metastasis, which can end up in a pathological fracture, lymph nodes which are causing ureteric obstruction, or if there is a spinal cord metastasis which is almost impinging on the nerves. These patients, we need to give bicalutamide at least for the initial 20 to 30 days. This takes care of the tumor flare, and after the bicalutamide, Zoladex is usually given in 2 weeks' time. After that, usually it is taken into the community where the patient will receive the Zoladex injections in the community by the community nurses. Then the patient will be seen by the radiation oncologist. They will plan for radiotherapy. There are numerous studies which have proven that there is no role for immediate radiotherapy. Patients can wait even for 3 to 4 months for the Zoladex to optimize the prostate cancer tissue so that when they receive the radiotherapy, the outcome is much better. So that's why you can see sometimes when the urologist refer the patients to radiation oncologist, the radiotherapy happens 3 to 4 months later. And the outcome is excellent for those who had neoadjuvant Zoladex. As far as the radiation oncologists are concerned, they divide the whole picture into a low risk, intermediate risk, and high risk prostate cancer. For low risk patients who requiring radiotherapy, they don't usually continue Zoladex for long term. For intermediate risks like 6 months, for high risk it's like 3 years. There are various studies which proven that high dose radiotherapy with short or long term Zoladex, especially in localized and locally advanced prostate cancer, has very good outcome. So this is the study which is called as DART1 study, where there is a 1:1 randomization where half of the patients received short-term androgen deprivation treatment, which is like 6 months, and half of them received long-term, which is like 3 years. The outcome clearly showed that there is a difference of at least 2 months of survival between the two groups, and the follow-up was 64 months. So in general, if there is a very high risk patient, the patient will need Zoladex at least for 3 years in the community. At 5 years, statistically significant improvement was noted in the overall survival in the patients with long-term compared to short-term Zoladex therapy. So these curves compare the long-term versus short-term Zoladex treatment. RTOG trials have compared the neoadjuvant Zoladex with radiotherapy and also with addition of the flutamide. As of now, flutamide is little bit age-old drug and we are using bicalutamide more commonly. And there is a good evidence to say that the overall survival, disease-specific survival, is favoring long-term androgen deprivation treatment. In the 10 years subgroup analysis of patients with Gleason score of 8 to 10, which is the highest Gleason score as we discussed, long-term adjuvant Zoladex have shown overall survival compared to the short-term Zoladex. There is no brainer that it's clearly proven that long-term Zoladex is a very good agent. These patients sometimes after 3 years of Zoladex will achieve very high improvement in the PSA, which is almost like less than 0.1 or non-assessable PSA levels. But these patients may have biochemical failure. So at the time, again, we need to revisit the Zoladex injections, which I will discuss again in the future slides. TROG trial has clearly proven that Zoladex as neoadjuvant therapy is very useful in locally advanced prostate cancer. They had a 6 months harm, they had a 3-month harm, and whenever there is a longer duration of Zoladex, the outcome is better. This graph clearly shows in a color-coded manner that if there is a radiotherapy alone given and 3-month Zoladex given and 6 months Zoladex given, the all-cause mortality is lowest for patients who had 6 months Zoladex injections when they were followed up to 12 years. It's a very long-term study. In the case of the metastatic prostate cancer, as I said, there are two options available. One is the Zoladex, the other one is the orchiectomy. If you read these two articles line by line and comb out the statistics, there is no major difference between these two. In fact, in the study by Walgrens et al., there is a slight advantage of orchiectomy in compared to the Zoladex. But why we prefer Zoladex compared to orchiectomy? These men are quite elderly. Already in their age, the erectile function and their manliness is in a kind of a very decreasing arm. The last thing what they want to know is that the surgeon wants to remove the testes so that the prostate cancer will be well controlled. It creates a kind of a lot of anxiety, and if you take some remote people, I come across some patients referred from mid Wales. There is a real group of patients who think that a manliness or the vitality or the ability to live is based upon the testes. And if a man undergoes orchiectomy, that really puts them off and it creates a kind of disconnect with the partner, and it has reasons for various psychological effects. So almost like I will say 10-20 years back, we started doing subcapsular orchiectomy where we'll remove only the hormone secreting tissues and try to maintain the shell of the testes. It doesn't produce a big testes presence feeling, but it gives a kind of a pseudo feeling of something happening in the scrotum. And overall, I have seen patients who had injections are much more confident. At least they have a pseudo belief that testis is producing some hormones, and that gives them a kind of a confidence in this very unfortunate part of their life. Zoladex is as effective as surgical castration, as we said, if we compare these two trials. And as I said, especially in this trial, the orchiectomy and Zoladex are very closely matched, while Kesari et al. Study clearly proven that Zoladex is as effective as the castration. If we compare all the three categories, as we said, like high risk localized, locally advanced prostate cancer, and metastatic prostate cancer, in every area, Zoladex has proved that there is a role. And especially the long-term Zoladex has proven to be of a better outcome compared to short-term, like 3 months or 6 months. And Zoladex is generally well tolerated, both at 3.6 milligram and 10.8 milligram doses. 3.6 milligram is for monthly dose and 10.8 milligram is for 3 monthly dose. I usually prefer the patient to start on 10.8 milligram because we don't want them to get missed out in the early stage. And once they got settled well, depending upon what they want, it's easy to change into a monthly or a 3 monthly dose regimen. The common side effects are, it's obvious, we are blocking the testosterone, so there will be problems with erectile dysfunction. Hot flush, it's almost equivalent to a woman equivalent of menopause, hyperhidrosis, and decreased libido. So these are all the main things patient needs to know. And the other common side effects which are much less prevalent were cardiac failure, myocardial infarction, decreased bone density, paresthesia, blood pressure, mood changes, depression. If you see these things tell us how much a testosterone is good for a man to have that well-being, both cardiac wise and bone health wise, and also a mental well-being. So because of the absence of the overall testosterone, these are all the side effects possible. It is easy to control these side effects just by asking the patient to keep their mood good, spend some good time with the families, keep themselves active as much as possible, and keep themselves occupied rather than sitting idle. A good occupied mind with, say, I will usually say the example like playing some Sudoku or chess will keep their mind good, and it prevents from depression and age related mental changes. Weight management is very important, so they should make sure that the calorie intake is nicely balanced and activities are balanced with the calorie intake. When you compare to the primary side effects, unfortunately, it's very difficult to treat. Erectile dysfunction, libido decrease can be balanced by counseling and also appropriate medicines like sildenafil, which you may be aware of. For hot flushes, we can give the patient cyproterone acetate, which is a good drug to prevent that initial menopause-like symptoms in a man. And this busy slide will tell us about the contraindications and warnings. Of course, this paper will be there in every injection leaflet, so that you may have come across already. As I said, administration of Zoladex is very special. It has got a safe system, and if you see the syringes, this is the actual size of the syringe as per the PowerPoint slide, and this is the 3.6 milligram. It has got a spring because of which the needle will be covered and withdrawn after application, so that it is very safe for the health person whoever administering the drug. And also there is a good finger drip, and the implant is biodegradable, and needle guard, it comes with a needle guard. So the syringe is prepared and reliably delivered, and it's ready to use, and it gives the delivery of the full dose, because every micromillimeter is important and we need to make sure the patient gets the benefit of the full dose. Zoladex consistently reduces the serum testosterone to surgical castrate levels. We can see from here that the gray is the 3-monthly 10.8 milligram dose, while the purple color is the 3.6 milligram dose, and both works equivalent. And there is an initial rise which we discussed before, like tumor flare. That's why initially we bridge the drug with the bicalutamide tablets for 4 weeks, and then there is a nice drop by 3rd week, and when the patient is getting the drug periodically, castration level is clearly maintained. So in summary, prostate cancer is a challenging disease. Unfortunately, this is a genetic disease, so we can't counsel the patients from their middle age and do this and do this, do that to protect from that. If there is a cardiac mortality or hypertension, diabetes, myocardial infarction, all these factors can be well controlled if a man is quite diligent in following the healthcare measures from the middle age onwards. But unfortunately, prostate cancer is a genetically transmittable disease, which is very unfortunate that you can't control it. If a man is supposed to have the prostate cancer, he will suffer it. The only way we can help them is by 2 main ways. As Dr. Vinodini mentioned, early diagnosis by PSA measurement in the clinic, giving respect to the patient's urinary symptoms, and early referral to the tertiary care. The second thing from our point is early correct diagnosis with correct MRI scanning, correct Gleason score, which two forms the baseline for the nice based stratification of the patients. And then based upon the stratification, we will treat the patient as localized, locally advanced, or metastatic, as we discussed. The last option available is for the metastatic patients, where the drugs are the only choice, but the patient should be motivated to maintain good healthy habits so that the side effects are nicely balanced. It is quick to administer. Zoladex has got this safe system, needle system, which is an intelligent method by which you can give the full drug in completion, and also is quite safe for the healthcare personnel who is delivering the drug. I'm quite happy to answer any questions either by chat or by just unmuting and talking. And this is the prescribing information again. Please feel free to scan this QR code so that you can send us the feedback form. We are planning to conduct a similar talk on different aspects in the future months. Fortunately or unfortunately, COVID made this Zoom or online based sessions so robust that we are able to reach to the clinicians in their own place, so that you will be not wasting your time in travel. And somehow I feel that these Zoom based sessions, if a person is attending, they can get much better outcome than traveling all the way and joining in a seminar hall, etc. I hope that's the same from your point of view also. So I will leave this QR code for some time for the participants to give the feedback. and the floor is open for discussion.
Thank you, Mr. Dhanasekaran. We have had a few questions coming in, and one of the questions is from Dr. Shamim, I think with regards to the side effects and risk profile of the Zoladex, asking how is cord compression happening, or how is that linked to the mechanism of Zoladex?
Yeah. So cord compression happens by the direct metastasis of the prostate cancer into the spinal cord. As you all know, prostate cancer is one of the organ present at the lowermost in the thoraco-abdominal region, and it has a very avid ability to spread to the lymph nodes and lymphatics. So the first group of lymph nodes is the pelvic lymph nodes, and once the pelvic lymph nodes were nicely saturated, it will get into the lymphatics and it will spread into retroperitoneum. This mode of spread predominantly causes ureteric obstruction because ureter is one of the commonest organ which can be easily blocked by the lymph node spread. The other method by which the prostate cancer spread is the skeletal metastasis. Skeletal metastasis can happen from head to toe, but say for example if a patient had skeletal metastasis in the shoulder or scapula, it is not a weight bearing bone, so the chances of a pathological fracture or life limiting events is very less. Having said that, two areas we need to concentrate is the weight bearing bones like femur and also the spinal cord. When the metastasis happens to the spinal cord, as you can remember, spinal cord is made up of the vertebrae, and inside which the nerve, spinal canal, the whole nerve bunch travels, and it can affect even in the lower bunch of nerves in cauda equina. Especially in the foramen where the nerves are getting released, those areas can be blocked. So thus the spinal cord metastasis can cause problems both by directly impinging on the nervous spinal cord or the nerve root entrapment. That's how the spinal cord compression happens.
Thank you, Mr. Dhanasekaran. We do have another question as well, which first of all says is from Dr. Eboya. He's saying, thank you for the webinar. How do you manage biochemical failure?
Yes. So first of all, what is biochemical failure? So biochemical failure means something which is failed in the form of the biochemistry. The biochemistry is the PSA. So biochemical failure can happen after surgery, after radiotherapy. Usually after surgery, since we are removing the organ completely, we expect the PSA to become completely non-available or less than, commonly mentioned in the lab as less than 0.01 nanogram. But in case of radiotherapy, even though the cancer cells are nicely fried by the radiotherapy, there is the prostate tissue still there. So prostate tissue can secrete some hormones. That's why the usual cutoff is 2 nanogram higher from the baseline. So for a patient with a PSA of say 25, he may reach a baseline of 0.5, below which it never went below after radiotherapy. So for him, we call the patient as got biochemical recurrence if it rises above 2.5. For a patient who reached a nadir of 1, the biochemical recurrence is if it is more than 3. So from the nadir, if it is more than 2 nanograms, we call it as a biochemical failure. Why it happens? Biochemical failure obviously shows that the prostate cancer is not completely treated. When the prostate cancer is completely treated, patient will remain with the 0.01 PSA for rest of the life. So if there is an incomplete treatment, or there may be a distant metastasis which we don't know, we thought it's a localized or locally advanced prostate cancer and treated the patient, but unfortunately the distant metastasis started producing the PSA. That's how the biochemical failure happens, either by surgery or radiotherapy. Once the biochemical failure happens, we can divide the patient into localized biochemical failure, where for example patient had radiotherapy but there is a recurrence in the prostate or near the lymph nodes itself. These patients we can do salvage surgery, by which the name implies we are removing the prostate and the lymph nodes so that we will still try to make the patient completely cancer free. why the biochemical recurrence happens due to metastasis like spinal cord mets or lymph node mets or any distant mets. Unfortunately, we have missed the bus of treating the patient or curing the patient. So biochemical recurrence has to be treated with the hormone management, and again injection Zolodex plays a very big role in controlling the cancers due to biochemical failure.
Thank you, Mr. Dhanasekaran. And then another question from Dr. Palaniandi. Is Zoladex treatment lifelong for patients with prostate cancer, or does it depend what classification of prostate cancer they fall into?
Yes. Again, as we discussed, there are three groups of patients like localized patients, locally advanced patients, and metastatic patients. It's quite clear that metastatic patients, Zoladex is a lifelong drug. There is no way we can stop them because the cancer has gone beyond the level of the prostate. So we need to make sure that it is kept under check. Even with a lifelong Zoladex treatment, there is a possibility that a patient may get relapse of the PSA. If the patient is on Zoladex and if there is a relapse, there is a role to add bicalutamide to the Zoladex, which is called as maximum androgen blockade. And the maximum androgen blockade can also fail at one point, and if the patient is maintaining good performance status, we can think about the other things like abiraterone, apalutamide, and other tablets, which are other injections which are available. Now, coming to the localized or locally advanced treatment, where if you are giving a radiotherapy, as I said, if it is a low or intermediate risk prostate cancer, radiotherapy, Zoladex is given for 6 months. If it is a high risk prostate cancer, given radiotherapy, Zoladex is given for 3 years. That is the present evidence. There is a possibility of failure in the later date at which we can restart the Zoladex later.
Thank you. We've got some good questions coming through. So if anybody else does have any questions, please feel free to put them in the chat or in the Q&A. We have a question from Dr. Khan, Mr. Dhanasekaran, which says, Zoladex seems to be for Gleason 7 and above, but how often should we be doing surveillance in Gleason 6 patients so we don't miss the window you referred to for patients who could be eligible for Zoladex and other treatments? And is surveillance for a GP regular PSA monitoring and referring patients for regular MRIs, or what would that involve?
Good. Thank you very much. That's a very important question because these are the group of patients where if tertiary level urology consultants or primary care GPs, if we are a little bit careful, we can maintain the patients in a comfort level throughout the life. As Dr. Vinodini said, patient will die with the cancer and patient will not die due to the cancer. So in the active surveillance group, it's not only Gleason 6, we can also apply Gleason 7 into active surveillance. The main aim of active surveillance is, we know the patient has got prostate cancer. Fortunately, it's a low risk, organ confined, low volume disease. So it should be low risk in the sense like the Gleason score should be less. Low volume, which means if you take the biopsies, we usually do 12 biopsies. So the number of cores involved should be 2 or 3 maximum. And also organ confined disease. Obviously, these low risk patients, there is chances of lymph node spread or distant spread is very, very impossible. So they are all organ confined disease. These patients, I think if you come across, usually tertiary care, we or our Macmillan team will keep an eye on them maybe for 1 or 2 years. Some patients behave so brilliant. In my view, I think the reason why some patients behave so nicely with active surveillance is they come to the terms with the disease. They understand that this disease can behave quite badly in the future, and they have to produce a strong health with a good mental capacity. I've seen come across patients diagnosed with active surveillance, prostate cancer, low risk patients, suddenly becoming a vegetarian, becoming very active, and it's a very nice change of habits. I've seen patients, PSA has come to normal, and sometimes we quite surprised after 5 years. We diagnosed prostate cancer, but now the PSA is normal for a few years. Are we really missed anything? Are we really overdiagnosed anything? The best protocol once the patient reaches the GP surgery for active surveillance follow-up is at least every 6 months to start with. There are some online calculators available. If you Google it like online PSA velocity calculator, if you place that, there is an online calculator. If you have to put at least 3 PSA values on the respective months like September 2020, August 2021, then it will give you the PSA velocity. The PSA velocity should be less than 0.75 nanogram per year. That is a good sign. That shows that the patient is not progressing, and even if it's progressing at a very low rate. So the major protocol for active surveillance is at least 6 months PSA measurement. If the patient is excellent and stable, every year PSA measurement and using PSA velocity. If there is a suspicion, sometimes we are nowadays using the advice and guidance method, which is quite good, and there is nothing wrong in writing to the primary consultant asking for there is a jump in the PSA, do you want to see, or what is the advice, so that maybe we will say keep an eye maybe every 3 months for the next 6 months or 9 months, and if there is further increase we will take it back and do further staging.
Thank you. That's interesting about the PSA velocity, and I haven't seen that calculated before, so I'll have to look into that myself. So thank you for that. We've got another interesting question from Dr. Malik here. Can you comment, Mr. Dhanasekaran, on the role of robotic prostate surgery, RE nerve sparing, and when this may be indicated compared with usual treatment that's been outlined today?
Yes. Robotic surgery is now the almost state of the art, especially for example in our region. The two main areas where it is available is Heartlands and New Cross Hospital. And truthfully speaking, if you see the outcome, we see the outcome based upon few things like the surgeon related outcome. How comfortable is the surgeon? Is the surgeon is able to do 3 prostatectomies in one full day, let's say starting from 8 to 5 comfortably? Surgeon related outcome. Then there is the patient related outcome. How patient is comfortable, how quickly patient goes home, how much of blood transfusion necessary, and is there any urine leak, is there any problems with erection? Patient related outcome. And third one is the cancer related outcome. How good the cancer in long term, whether is there any early recurrence or not recurrence in the presence of robotic. If you divide these three, cancer related outcome, there is no difference between robotic surgery or open surgery or laparoscopic surgery. So the method is not going to affect the cancer related outcome. Patient related outcome, yes, patients will go home early, need for painkillers or less, and there is a good possibility that a patient will be having a better nerve management and nerve preservation, and so better erection problems. Surgeon related outcome, it definitely makes a big improvement. The surgeons who had the difficulty of doing open prostatectomy and also using the laparoscopic method, which is not very good for the ergonomics of the shoulder, back, etc. Somehow we were not much concentrated on the surgeon related comfort in the long-term management of the surgeon's health in the previous decades. But nowadays robot has really made the surgeon to sit and operate with good magnification, so that the surgeon is kept on its own comfort level, and he can do even 3 prostatectomies in one day compared to usual 2 prostatectomies what we have done during the age of the open prostatectomies. So I will certainly say that robotic surgery have a very good improvement in surgeon related comfort and also the patient related functional outcomes, but there is no difference in the oncology outcome.
That's really interesting, Mr. Dhanasekaran. I have to say I've never really thought myself about things from the surgeon's perspective, and actually, like you said, the ergonomics and occupational health side of things from the surgeon's point of view. And I think now we are starting to talk about how we can look after our colleagues and GPs and surgical colleagues as well. So yeah, that's an important consideration. Actually, it improves efficiency as well, as you say, if you can do more surgeries and for a longer period of time if you're in better health as well, isn't it? So that's really interesting. We have another question from Dr. Chowdhury, who's always trying to see what we can do better in GP land. So he's saying, in practice, can we request those MRI scans to help you in making and help us in making the diagnosis in the first place?
I will say big yes, and that's one of the questions to be even I usually ponder why GPs were not given the power to do an MRI scan, because it is quite clear now with the nice guidelines, the recent one in 2020, it's everything is nicely labeled, and if a urologist can do after seeing a PSA MRI scan, it should be reachable for the GP also. I mean, historically speaking, the reason, I mean, sorry, I may be ignorant on that. The reason why the GPs were not given the chances to do MRI scans or a free hand on CT urogram, CT KUBs, maybe there was a wrong belief that the utilization will be too much, and then unnecessarily using the precious resources. They are very precious, there is no doubt in that. But I think the day should come that we should be able to train, and everything is protocolized. Especially I, in my clinic, if there is a junior trainee sits with me, it just takes 10 days for he or she to learn the complete protocol. There is nothing more to teach after 10 days. So GPs should be empowered to do the MRI scan. And the advantage is, if the MRI shows no suspicion, there is no need to refer to the urologist, because a lot of times you may have come across raised PSA, referred to the tertiary center, MRI done, MRI showed normal, PIRAT 2, so referred back to the GP. So the whole circle is a waste of money and time for the patient. So I strongly advise it. Maybe Prostate Cancer UK should consider doing some steps in that. We may be able to do at least locally as a trial and see how it goes on. It all depends upon CCG, isn't it?
Yes, yes. Financial implications and more politics involved, isn't there? We do have another question as well, Ms. Dhanasekaran, from Dr. Boskany, who's asking, with regards to the hot flushes that could be a side effect of Zoladex, how would you suggest managing those hot flushes, which are as a result of Zoladex?
Yeah. So first is the patient education. So hot flushes, as I said, is just equivalent to the female equivalent of menopause. So what is happening is, once the luteinizing hormone is blocked, the temperature regulation is blocked. So automatically now, compared to the waking state where a man is driving a car, doing his job, etc., when he goes to sleep, his core temperature should become little bit on the lower side, and that regulation is lost. So that's why the hot flushes especially happens in the night, and sometimes it's very troublesome. I've seen patients who are waking up in the night with completely drenched in the sweat. They don't they feel so uncomfortable. The whole mattress got completely wet, as if somebody has thrown a bucket of water on them. And so the first thing is patient education. Patient should be educated that this is due to the blockage of the luteinizing hormone, and this is how it happens. And there are various good drugs available. Cyproterone acetate is a good drug, and sometimes even if you give it for like 3 or 4 months, slowly that hypophysis pituitary axis get kind of balanced out, and the patient will feel better. And having a nice ventilated house, and then having good amount of water to prevent dehydration will also help. But once a patient understands the reason, they are more confident. The main problem is the patient's fear. Why this happens? This means something like a prostate cancer has gone from head to toe. That's why I'm sweating from head to toe, something like that. So it's very important to educate the patient, and cyproterone acetate is a good drug.
Dr. Chowdhury's got his hand raised, but I'm not sure if he's able to speak because of the panel layout. Dr. Chowdhury, if you do have a question, please feel free to put it in the chat or in the Q&A, and we can try and address that for you. And likewise, if anybody else has any other questions, please do either put them in the chat or in the Q&A, and we can address those. But it's 5 to 8, and we're doing well on time otherwise, which is quite good. Thank you everyone for spending some time with us this evening, and your questions and the interactive side do really bring these alive. Thank you, Dr. Shamim, for joining us as well. He's thanked us for the meeting today. There will be some other meetings coming up as well in the next few weeks and months, and we will keep you updated on those. So thank you, Mr. Dhanasekaran, for joining us tonight and for giving up your time to share some of your expertise. Thank you, everyone, for joining.